He's now leading the ICU in Singapore. He has a lot of publications to his credit, and he currently leads the courses group of ECMO education at ELSO, and is the co-chair of the Scientific Oversight Committee and Data Review Committee at ELSO. Words of all this apart, he's a good friend, a constant supporter, and always a mentor to all of us. So, sir, without wasting much time, on behalf of Nephrocritical Care, I welcome you here.
Thanks for that lovely introduction, and all of you would probably be at the fag end of the course, and hope you enjoyed this great course so far. I can still see you all without tired faces, which means to say the course has had a great impact. My talk today is on acute kidney injury in refractory cardiogenic shock. To me, this talk essentially underlines the importance of organ crosstalk, something which humans are trying to decipher, and especially when organs fail, the crosstalk is so intense that some of these organs even fail. So while we try to decipher how this mechanism works, clearly, we also need to know some of the recent paradigm shifts that has been happening in this field of organ failure. First and foremost, let me take you through some of the paradigm shifts in the concepts. Clearly, the classification of cardiogenic shock in the last 5 years has seen some changes, especially with the SKY classification coming up in a prominent way. They have classified shock into 5 stages. Stage A, where they identify patients at risk, and stage E, where patients have already had a collapse or a cardiac arrest. The rest of them fall in between. So again, this stratification of cardiogenic shock takes into consideration 2 important things: the presence of hypotension and hypoperfusion of organs. And that's where, this talk is going to be related or interrelated with how I am going to connect it to cardiorenal syndrome. Now, not just that, you need to also understand that the field of cardiogenic shock is clearly advancing in a big way, to the point that when patients with cardiogenic shock get started on vasopressors or inotropes, we have identified that their dosing clearly impacts on in-hospital mortality. So when you have your patient jump from 1 inotrope to 2 inotropes, the mortality just jumps by 6 to 8 times. Going on to say that this also impacts on organ hypoperfusion in a big way. So the good thing to happen from a cardiogenic shock perspective is the fact that this classification has helped us come up with a global definition where critical end organ perfusion has been defined well. There are well set, at least, criteria for diagnosis, and there are clearly signs of impaired organ perfusion that has been highlighted as part of this definition so that the management can be tapered accordingly. So with this in the background, now I take you to another aspect of the same thing, the same cardiogenic shock affecting your kidney, causing AKI. And clearly, that's the time when we come up with facing patients with cardiorenal syndrome. I mean, as I said earlier, a part of this has been covered yesterday, so I'm not going to the details of it. Clearly, the hemodynamic crosstalk leads to inflammatory molecular signatures and neurohumoral markers, which clearly affect kidney function in a big way. And the heart-kidney interaction happens across several interfaces, none of which is going to be, important from clearly understanding a pure theoretical aspect. What I have to go through or take you through is the practical aspect of how you deal with this. They've identified 5 types of cardiorenal syndrome, of which the patient who has AKI secondary to cardiogenic shock would fall into the type 1 AKI, where heart failure leads to AKI. And that's the most common type of cardiorenal syndrome that you encounter in day-to-day practice. And as far as AKI in cardiogenic shock happens, it can happen as a result of not just acute decompensation and ischemic insult. It can also happen as a result of interventions we do, as a result of, some of the treatment modalities that need to be followed. Say, if this patient needs cardiac surgery, they eventually end up getting cardiac surgery related AKI in the postoperative period. So as much as facts about cardiorenal syndrome 1 and other cardiorenal syndromes go, when you compare that, you might find that the presence of AKI is just an independent mortality risk factor in patients with acute decompensated heart failure. Now, whether this is secondary to STEMI, non-STEMI, or other cardiogenic causes, anything that reduces LVEF causing AKI increases your mortality. And if you look into some of the epidemiology of such an AKI, 1 in 5 patients that get admitted to your ICU get that. And about half of the patients who reach your ICU with a positive blood culture and septic shock also get that. Going on to say that these are things that you encounter day in, day out. So why are we discussing it again if you know that you face day in, day out? Now, there are certain things about management that needs to be underlined and that we need to be careful about when we deal with a heart patient who's got acute AKI. 1, these people have certain risk factors. And of course, these risk factors are quite popular by the way that they are risk factors for coronary artery disease as well. And not just that, I just thought I will bring in a case history here, and this is how Tapas wanted me to do this session, so that you understand what aspect or what perspective of AKI I'm trying to bring up here. So let's talk about this classic patient who gets acute decompensated heart failure in the context of diabetes mellitus and hypertension. So he clearly has the risk factors for CRS. He's now in cardiogenic shock with a blood pressure of 100 systolic. CVP is around 15 and he's got peripheral edema. His creatinine is rising. His echo shows an EF of 35% and he's got ascites and pleural effusion. Now, as part of his initial management, I mean, if you go by cardiogenic shock states, he probably is in stage B of cardiogenic shock, starting of stage C. And appropriately, he was started on vasodilators to relieve the heart from a high peripheral vascular resistance. Now, as part of the management, this patient was started on diuretics. And on day 1, the team managed to achieve a fluid balance of around -2 liters. Now, as it would happen, it will always happen after treatment has begun. By day 2, you find that his urine output is waning down. It's clearly below normal over the last 5 hours. Creatinine has taken a massive jump. Peripheral edema still persists. And this is the moment of conundrum where you think too many things in your head. Is this patient adequately decongested? Have I diuresed this patient enough? But this patient has heart failure. So how much do I diurese him if the kidney function is worsening? Or do I give him fluids? Because I'm not entirely sure of how to guide fluid therapy in this patient. Clearly, these questions run through our head, especially after we start treating him in the ICU and after you see an initial worsening of the clinical or the biochemistry that you order for. So how do you approach this conundrum? As I said earlier, most of the cases of CRS1 happens in the context of acute decompensated heart failure. Clearly, acute coronary syndrome and cardiac surgery are big drivers of CRS type 1. Now, why am I worried about this patient? I'm worried about this patient for many reasons. 1, I've already started him on diuretics and vasodilators. And if you look at this graph, and this was, say, 10 or 15 years ago that it was published, the mortality just goes up the moment you start inotropics. And I showed you that even in my slide where cardiogenic shock is treated with inotropes, you get to see a big jump in mortality. So the same thing happens here where, in patients who have AKI, the in-hospital mortality also jumps up when the patient is on inotropes. So I would try as much as possible not to glean onto this. However, if I am forced to do that, I will have to do that in the aspect of, getting this patient decongested. It's not just that. There is another concept that is coming up in a big way, the concept of worsening renal failure, or WRF. So patients who get started on treatment, especially in the context of those who already have an element of heart failure and there is acute decompensation of it, these patients can experience a worsening renal failure. And this worsening renal failure has been stratified into class 1, 2, and 3 based on the amount of increase in serum creatinine or decrease in GFR. And you would find that, as this graph rightly points out, if your patient's baseline renal function is bad, so let's say you start off with a patient who is in acute cardiogenic shock, but also has a baseline creatinine that is quite high, his odds of dying is quite high again by virtue of this episode of acute decompensation. And this death is not just related to acute heart failure, it's related mostly to acute kidney injury as well as the other multiple organ dysfunction that ensues. So if you have to manage this patient from here on, the management principles are more or less the same. The primary driver of any cardiorenal syndrome, especially type 1 cardiorenal syndrome, is venous congestion. So if that is the sine qua non of CRS1, the management essentially should be decongestion at all costs. Now, how are you going to evaluate these patients for both heart failure and kidney failure at the same time? And that's something, which is coming up in a big way in this field. I believe that, a lot of my talk on the next few slides, I would be highlighting how you try to balance monitoring these two organs while making sure that your patient improves. Things like intrarenal venous flow patterns are also becoming popular in identifying renal venous congestion. And people have looked at its prognostic impact in CRS type 1. So first and foremost, you need to understand the pattern of disease you are dealing with. Now, there are different ways of circulatory congestion. So you need to understand how your patient presented to you. And that clearly falls on how much of history you have taken. So if this patient has a fast circulatory congestion, a rapid buildup of fluids, and essentially, clearly sympathetic activation, this patient falls into a group where you might have to decongest them immediately. Now, there is the other group where this same mechanism is slow and you will have enough time to think and act. So clearly, the essential part of treating this patient is to assess whether the volume buildup was fast or slow. And again, you use imaging modalities such as POCUS and VEXIS to ascertain your findings. What you then do is clearly, dependent on the stage of shock he arrives in, invasive hemodynamic monitoring makes an important impact on how you manage this patient. Now, how to decongest this patient based on their fluid status and dry weight? Clearly, there are gray areas here which cannot be, which has not been sorted out yet. But we still use some crude methods to clearly, make sure these patients are decongested. On top of that, clearly, venous congestion, there is a backlash of venous congestion on other organs and the whole blood volume as such. So clearly, it precipitates for a vicious cycle of ongoing heart failure too. Now, one of the important things that gets highlighted here is the use of biomarkers in cardiorenal syndrome. Now, there are renal biomarkers, there are cardiac biomarkers. The question is, how useful are these in these scenarios? and which one to use. Now, while I have listed the list of renal and cardiac biomarkers here, some of the most commonly used ones are the Nephrocheck kit, which uses TIMP and IGF-BP. And the use of Nephrocheck has clearly been validated in the context of cardiac surgery-associated AKI, where type 1 CRS can happen soon after cardiac surgery. Now, so clearly, going on to say that these markers can predict AKI 72 hours before the clinical rise in creatinine by the bedside or drop in urine output. So there are bundles available in cardiac surgery whereby you look at preventative strategies to reduce CRS based on biomarkers such as Nephrocheck. Now, I'm not going into the details of this now. We will talk about this later, where we combine a few of this to find out solution to how we manage our patients. As I said earlier, decongestion is important. The question is, if your creatinine is rising, is it still worth the attempt? Now, evidence clearly says that aggressive decongestion, even with worsening renal function, it will improve outcomes. So for patients who achieve hemoconcentration, they clearly, tend to do better clinically and get discharged from the ICU than those patients who have a rise in creatinine but are not decongested. And if you look at this nice study, which was published a couple of years back, they used the staging of worsening renal failure, and they used brain natriuretic peptide as the marker of congestion, and showed that patients who have no worsening renal failure but reduction of BNP, going on to say that you're decongesting them effectively, have the least mortality, or when compared to those patients where decongestion is effective, you find that when there is a drop or when there is no effective decongestion, as seen by no reduction in BNP, the odds of dying is quite high. The kind of patients who do clearly well are those patients with no worsening renal failure and higher BNP reduction, as well as patients with worsening renal failure and higher BNP reduction. So look at this purple graph as well as the blue graph. So worsening renal failure with no reduction in BNP clearly are those cohort that are not responding to your therapy well, and they are at high risk of mortality, even if your patient has a worsening creatinine on your bloods next day. Then comes the question, how much and how fast am I to do this? Clearly, this patient has ascites, pleural effusion, and removal of third space fluid clearly helps up to a certain extent in decongestion. But the mainstay of therapy in these patients are diuretics. Clearly, diuretics, as we discussed just now, to the point, even if there is worsening renal function, if you are able to achieve hemoconcentration, and if there is still ongoing urine output, I would push these patients using the diuretics. The question then comes as to whether there is a role for intermittent dosing or continuous dosing, and what you should monitor as part of conducting these patients. Clearly, if you look at the evidence for how the diuretics should be given, there is no major difference in outcomes between oral versus IV diuretics. Bolus versus continuous diuretics, clearly the dose trial showed no major differences between outcomes, going on to say that both are equally acceptable. Between low dose and high dose strategy, no major differences in mortality, except that the high dose strategy patients had a few more side effects of furosemide than others. Going on to say that, a conservative diuretic strategy, but definitive diuretic strategy works in patients even with worsening renal function. Now, one of the things you will encounter as you manage these patients, especially in the context of those with acute on chronic decongested heart failure or decompensated heart failure, is diuretic resistance. It happens due to many reasons. And if these patients are not presenting for the first time in your ICU, they come to your ICU for the third time, fourth time, you will find that a lot of these patients develop diuretic resistance. It can be due to many of these mechanisms. I'm not going into the details of it, but this is a phenomenon you should know that readily happens. Now, to assess diuretic resistance, it's best you understand diuretic efficiency. Now, that is a concept which is, again, new, and it's coming up, which focuses on quantifying the renal response to a fixed dose of loop diuretic. It's considered as a prognostic marker in cardiorenal syndrome type 1. And essentially, it's to give you a rough idea of what it is. I'm again not going into the details of it. It's a ratio of urine sodium to urine furosemide, and that's what you use to assess your diuretic efficiency. So if the diuretic efficiency is poor, these patients are more likely to experience worsening renal function even in the context of decongestive therapies. And in such patients, you might have to increase the dose of loop diuretics, add in a second diuretic to increase diuresis or to cause diuresis. Things like dopamine have been tried in the past, and clearly, right from 1964 when it was first published till now, dopamine only increases the renal blood flow to an extent that it reduces, it improves your urine output, but per se, dopamine has not been shown to improve outcomes in patients with type 1 cardiorenal syndrome. And of course, these things have been proven in subsequent meta-analysis as well. Now, there are other ways of modulating this patient's neurohumoral system. Clearly, it has shown a lot of promise of late. Selective V2 receptor antagonists, recombinant BNP, and of course, as I said earlier, selected patients who need inotropes would benefit from this therapy as well as ongoing diuresis. Now, when do you stop diuresis and start thinking about the next important step, that is ultrafiltration? Now, the data or the evidence for ultrafiltration in type 1 IARS, CRS, is quite mixed. So to cite you two important studies, the UNLOAD study and the CARES study. The UNLOAD study clearly showed that there is a massive or a significant improvement in mortality in patients. Sorry, there is a significant improvement in renal function in patients who get ultrafiltration, while the CARES study didn't show any much significance. Now, these are the list of trials that have been, published as part of ultrafiltration in type 1 CRS. As I said earlier, ultrafiltration was favored more than diuretic therapy in the UNLOAD study, but all other studies, including the AVOID HF, the CARES HF studies, have all shown that the outcomes are similar in both groups. In fact, some of them even showed a higher risk of side effects with ultrafiltration arm. Going on to say, we all know dialysis involves an extracorporeal circuit, and clearly the complications cannot be undermined. Now, after listening to all this, how am I going to manage this patient? One of the important things that you need to consider here is the fact that we all think one size fits all. I would rather, question that approach and say that, any patient who presents with such a syndrome would just need diuretics to treat him, or he would need ultrafiltration to treat him. So we need to clearly look at some of the parameters. Some of the adjuncts can be used to titrate therapy. Clearly, there are dogmas and facts in clinical medicine. The fact that we still use furosemide as part of treatment of this patient, who, if he comes in acute pulmonary edema, clearly shows that we believe furosemide still works, while there is no trial till date to say that furosemide is superior or is the drug of choice otherwise based on evidence. We still use it in clinical practice because we have been using it all these years. And for all of you who think that furosemide in this setting causes diuresis and hence improves symptoms, you are still under the dogma. The fact is that furosemide, when given intravenously, causes rapid vasodilation to the point that it relieves symptoms faster. So you would find that your patient who gets furosemide when he is in acute pulmonary edema, he would have relief of symptoms within 30 minutes, but the diuresis would start later, just underlining the mechanism of furosemide in this particular setting. So in this patient who now has a type 1 CRS and a worsening renal function, how do you combine worsening renal function and biomarkers to suit his therapy? I mean, of course, Clearly, one can use natriuretic peptide as a biomarker and look at how bad the renal failure is and whether the natriuretic peptides are coming down, because we clearly saw that the outcomes are quite similar when they are decongested well. As long as there is worsening renal failure as well as no reduction in natriuretic peptide, you can stay put that these patients are good candidates for diuretics. The other approach essentially is what Abhilash and colleagues have put forward based on POCUS. So clearly, they have renamed this whole worsening renal function stages as permissive AKI and low cardiac output AKI and congestive AKI. And based on a POCUS-based diagnosis, as well as some clinical parameters, they have formed an algorithm, which again can be useful by the bedside when you treat type 1 CRS. So for this patient with acute decompensated heart failure, I did end up starting him on 4 mics of dobutamine. I used that to increase his diuretics, and clearly, within a few days, couple of days, the serum creatinine started going down. He diuresed a lot. So he was one of those who had worsening renal function, but had good response to diuretics. He never had any diuretic resistance. So eventually he did not need another angiogram or cardiopulmonary bypass. My backup plan was always there that I would go on CRRT for this gentleman. Now, as this patients leave ICU, you need to plan that the severity of CRS is addressed and they don't recur quite often, because a lot of these patients get re-hospitalized for the same reason. And that's where, you need to address some of these aspects of these patients going into chronic CRS with appropriate drugs. So ACE inhibitors, clearly patients who have diabetes would need SGLT2 inhibitors, and clearly, other therapies if required in the context of cardiac failure, say such as cardiac device therapy and maybe even kidney transplant, might have to be considered if admissions become recurrent. One thing which has not been highlighted, and I have to do that now, especially in the backdrop of high mortality, high healthcare resource use, and poor quality of life of these group of patients, is the fact that these patients might need to be palliated at some stage. So clearly, you have enough treatment options, but you need to understand that not all patients can be rescued with your medical therapy or your interventional therapy. A few of them would need palliation. Clearly, these patients have a neuropsychological impact, and they have, highly prevalent depression as CRS progresses. And of course, this depends a lot on resources in this setting. So to conclude, from a current state where we think one size fits all, and we focus on individual biomarkers, the future essentially of such patients, when you manage them, you need to go for an individualized approach. You need panels of biomarkers that looks at both cardiac as well as renal origin, and you may have to combine them when you use them. You'll have to diagnose the type of worsening renal failure in AHF when you treat them. And in terms of research, it's not enough that we just look at major adverse renal events or major adverse cardiac events. Future trials should essentially combine both these events together, as well as include, milestones such as need for dialysis, need for hospitalization as part of critical events or cardiac, these events when you measure composite outcomes. So the take-home message from this talk essentially should be that you need to figure out, one, that this is true AKI in the setting of heart failure. When you treat these patients, please make sure you identify diuretic resistance and you optimize your decongestion in CRS type 1. You may need to combine biomarkers, and that becomes the new paradigm in the algorithm for evaluating heart failure with AKI. Most of these patients would go into chronic CRS, and that would need monitoring. Palliation is an acceptable approach in these patients, especially with advanced heart failure or renal failure. The societal guidelines talk about a multidisciplinary approach to this problem. Clearly, if you look at cardiology guidelines or nephrology guidelines, the onus is on the cardiologist and the nephrologist to sort this out. But I feel that there is an important role for the intensivists here, especially in type 1 CRS, when you treat them in the ICU. So multidisciplinary approaches should involve intensivists, and I hope future guidelines include them as part of the multidisciplinary team when we manage patients with CRS. Thank you.
The question was, when will you consider palliative care in cardiorenal syndrome?
Tough one. If you look at the perspectives, it can be different and that's where, these are things where we don't have a clear-cut consensus. And I'm sure, we all have our own ways of assessing the severity of the disease. To me, a patient who is not a candidate for things like transplant, or a patient who gets readmitted to ICU for more than 2 times with no other definitive therapies in the pipeline, these patients, at least, we should be entertaining the talk of palliation with the patient as well as the patient relatives. It may be a bit too aggressive, but very often in our setup, if we don't start it at that point, this readmissions will happen for a longer time. Even if we start during their second readmission, you will reach a consensus first among the multidisciplinary team and then with the patient only by the 4th or 5th readmission. So clearly, I would think you should start at least considering it with the second readmission.
Just to make it's my doubt, did you mean end of life care?
No, limitation of care.
I didn't hear you, sorry.
Limitation of care. Limitation of care.
Yeah, okay. The experience regarding dapagliflozin in the acute heart failure.
No, we don't use it here. Clearly, these are pulled out of the recent trials and the American experience. We don't use it in a big way here.
Yeah, this new machine called Aquadex can use it through the peripheral cannulas to do ultrafiltration. I think it's available in India, but not that much. It doesn't pick up that much. I'm not sure is it available there. I'm not sure. So
Aquadex, whereby you do peripheral cannulation and do ultrafiltration. Is that what you're trying to say?
Yeah, it does. If I remember correctly, the circuit volume, the extra corporeal volume of blood at the time is going to be around 50 ml, I think. Yeah, and you can do it with 2 peripheral gauge cannulas, so you don't need the central line, etc.
Yeah, I mean, I agree that miniaturization of circuits is something which is becoming popular, especially with home-based dialysis and other things happening. I'm not aware of this Aquadex, to be honest. We are not using it in Singapore either. We still refer patients to the nearby dialysis center. But there are a lot of things that are happening with the dialysis circuits now. Patients with respiratory failure are being considered both for respiratory and kidney dialysis with the same machine. I mean, I'm probably, I agree that, miniaturization is the way to go. So things like Aquadex will really revolutionize how we do dialysis in future.
Thank you so much.
Thank you. Thank you. Thank you for having me in. Thank you.